Welcome to part two of Fundamentals of Nursing. So now we're going to talk about pain. Pain is very important because pain is what it means to the patient. So when we do a pain assessment, again, remember to do your pain assessment the same way you always do so that you remember where you are in the pain assessment and that you can get a true, accurate pain assessment from the patient. So we have the PQRSTU mnemonic. So P is for provocative or palliative factors, such as what makes your pain better or what makes your pain worse. Q is for the quality. So, for example, we're going to use open ended questions as we're always going to do in nursing and nursing school. Tell me what your pain feels like, or tell me about your boo boo if you're talking to a little child. R is for region or radiation. So, show me where your pain is, or show me where your teddy bear hurts, of course, if you're working with a child. So does the pain, where is it on the body and does it move anywhere? Severity. So we need to ask, using a pain scale that we're going to talk about, how severe is that pain? Again, we're always going to use the pain scale, the same pain scale with the same patient every time we do this. So we're going to talk about those in a little bit, but with adults, we usually use a numeric pain scale. With children, we use like the FACES pain scale. So the T is for timing. So is this a constant pain? Does it come and go? Is it continuous? Is it kind of a combination? We can ask if the pain increases or decreases during specific times of the day or with specific activities. And we want to know how is the pain affecting you in regarding activities of daily living, going to school, if they're children, playing, in your relationships and your enjoyment of life. Now, there's also another pain assessment to the right. Is you can remember old cart. So O is for the onset of the pain. L is for the location of the pain. D is the duration of the pain. C is the characteristics of the pain. So again, is it burning, sharp, stinging? Um, A is for the aggravating pain triggers. So when I get up and walk around, it hurts more. R is for relieving factors. So when I sit down and put my legs up, it hurts less. And then treatments, what have you tried to reduce the pain, such as over-the-counter medications, hot, cold. It doesn't matter which mnemonic you use, as long as you get all of these characteristics, then you should be good to go. So in talking about the pain scales, we have a numeric rating scale or an NRS where we use numbers to rate the pain. We can use visual analog scales called the VAS that we can use with children, where we have them point to the picture that matches their pain. Or we have categorical scales where we use words and possibly numbers with colors and locations that we might use with the younger population as well. So there are different types of pain scales that you need to be familiar with. So we have the FLAC pain scale. Uh, it's based on observations made by a healthcare provider. It's used to evaluate young children, and it's really good for anyone who really cannot communicate. So we look at their facial expression, their leg tension or relaxation, their activity, their crying, whether we can console them, and then we have 0 to 2 points are assigned for each of the 5 categories, and then the overall score is tallied, and then that's how we figured that pain scale out. So FLAC, the FLACC, just remember facial expression, leg tension, activity, crying, and can we control them. Next, we have the CRIES pain scale. I like these because they're all mnemonic, so they're easy to remember. So we have crying, oxygenation, vital signs, facial expression, and sleepiness. So we use this for babies 6 months and younger. It's used a lot in the NICU. So again, we're going to use the healthcare provider's observations and objectively measure what their pain level is. So 0 means no pain, and a rating of 2 means you're showing signs of extreme pain. Then we have the Wong-Baker FACES pain rating scale. This is kind of most common you'll see in the pediatric wards. It's preferred by physicians, parents, and children. It's very inexpensive to make, but it's easy. So you have the child point to how he or she is feeling. You can see we have 6 phases. It goes from 0 pain to 10 pain, where it hurts a lot. Here's just a basic numeric pain scale that we use for, young adults and adults on a scale of 0 to 10. How's your pain? 10 being the worst pain, 0 being no pain. So pain, types of pain and treatments. So we need to know that acute pain is a new or sudden pain, and the vital signs are going to be impacted. So think about somebody with an appendicitis. They were fine, and then all of a sudden their right lower quadrant started hurting. They're in a lot of pain. They're bent over, and they're probably going to have um, high blood pressure, high heart rate. Versus chronic pain, where this is where the pain persists for a long time and your body adapts to it. So the vital signs might not be impacted. Chronic pain is usually longer than 3 months. And then we have breakthrough pain. So think of this as like surgery pain. So we have somebody who just had surgery. We're trying to keep them medicated on pain meds, but they might have that breakthrough pain where they need PRN medications. And then, of course, we have cancer pain, which is horrific, but it's related to the cancer and the treatment itself. So people with cancer pain will be on higher doses of stronger pain medications. So where does pain come from? So we have these nociceptors, and their job is to pick up painful or noxious stimuli, and this will cause like an aching or throbbing pain versus a neuropathic pain where we have injury to the nerves. And this is more of like a burning or shooting pain. So think about peripheral neuropathy, where the patients say that they have like a burning sensation or shooting feeling in their toes or on the periphery of their extremities. And then we have idiopathic pain, where we don't know where it's coming from or what caused it. So just know that there are different types of pain and the treatments will be different as well. We need to know that there are different locations of pain. So locations differ based on the pain. So we have visceral pain and somatic pain. So I tried to give you some diagrams here. Somatic pain comes from the skin, muscles, and soft tissue, while the visceral pain comes from the internal organs. So it's really important to ask your patient exactly where the pain is, what caused it, what were they doing when the pain started. It'll kind of give you an indication if this is visceral or somatic pain. So therapy for pain. So of course our job is to keep our patients pain-free or at least have limited amount of pain as possible. So we're going to use pharmacological and non-pharmacological medications. We try to start off with the NSAIDs, right? Like Motrin, ibuprofen, naproxen, because we don't want to just jump and give everyone opioids because opioids can be addictive. But if they need it, they need it. So we do have the narcotics for moderate to severe pain. And then we have the adjunctive medications. So you might see somebody with chronic pain on maybe an antidepressant along with an NSAID. Of course, we have non-pharmacology pain or therapy. So we try to, of course, stay away from the medications because we don't want our patients to have any side effects or become addicted. So we always try to encourage massage or biofeedback or meditation. Now, PCA pumps, these are great. These are patient-controlled analgesics. So it's a pump that the patient is the one controlling the medications. Okay, so it's really important that only the patient pushes the button for the PCA pumps. Um, when the pain occurs, the patient pushes the button. The patient has an IV, and the medication is given in small doses. You can't just keep pushing the medication, the button, get continuous medication. It's set on a timer, and then hopefully the patient doesn't need it every single time that the medication is available, but it is available for that breakthrough pain. So the nurse will need to verify with another nurse the pump settings to make sure it's set up appropriately and the timing is appropriate. We need to educate the patient that only the patients touch this. A family member can't just go up and touch the button. And we need to know that even though we're giving small doses of medications at a set time, The patients can still suffer toxic effects, so we need to be always monitoring our patient, assessing our ABCs, airway, breathing, circulation, especially with those narcotics. We need to watch our respiratory. All right, welcome back to the NCLEX review for Nurse Muse. So now we're going to talk about communication. It's our favorite. So we need to understand that communication is made up of the sender, the receiver, the message that is given, and the channel that we're speaking through. So it can either be verbal or email or text message, and then the feedback that we receive from that communication. So there are different levels of communication. So we have intrapersonal, interpersonal, small groups, and then public communication. So intrapersonal is where you talk to yourself inside your head. Interpersonal is between you and somebody else. Small groups, that's like a nurse manager or nurse educator giving a small group an in-service. And then public communication, we can think about larger groups such as the media, or publishing something in an article or in a magazine. Nonverbal communication. So nonverbal communication, as you can see on the left-hand side, makes up 65% of our communication. So when we're speaking to somebody, people are looking at our posture, our body language. If we're slumped over and our arms are crossed, they might not be willing to come up and talk to us because we don't look very approachable. They're going to be looking at our expression. Do we look angry? Do we look bored? Do we look happy? Are we smiling? Eye contact. So just remember that eye contact, looking at somebody in the eye in the United States, is a sign of respect, but not all cultures see this as a sign of respect. So you need to be culturally aware with eye contact. But in the United States, having eye contact with people you're speaking to does show a sign of respect. Gestures, we need to be very careful with gestures because they are based on cultural beliefs again. So some cultures giving a thumbs up is a rude gesture. Nodding could be seen as not really paying attention. So be aware of the culture that you're working with. Touch. We do use therapeutic touch in nursing when it's appropriate and when it's safe. I wouldn't use touch with a patient I just met. I wouldn't use touch if I didn't ask permission. I wouldn't use touch with a patient who's actively psychotic or who isn't safe. So it can be therapeutic when used in the appropriate way. Silence. Therapeutic silence is okay. It might be awkward at first, but actually giving people time to think before they respond is a sign of respect, and it will help the patient feel like you're not rushing him to come up with an answer. So therapeutic silence is okay. Roles. So if you want to think about how to have a relaxed posture so that people feel like they can approach you, think of roles, the mnemonic roles. So you're relaxed, you have an open posture, you lean in to the person who's speaking, you have eye contact, and you sit squarely so the patient can see that you're actively listening and talking to him. So therapeutic communication, this is huge on the NCLEX, it's huge in, I'm sure, on your exams in class, but this is how you communicate with your patient, and that they feel that you truly care about their well-being. So to use therapeutic communication, we have to use open-ended questions. So we don't like to use closed-ended questions, which are we call for an answer for yes or no. We need open-ended questions, such as tell me more, can you explain more? We need to offer self. So being with the patient, staying with the patient. If the patient is scared or anxious for a procedure, can you be there with him? Can you be in the room? Restating, that's important, saying what the patient has just said in your own words to confirm that you understand what the patient is saying. So over here on the left, active listening is something that you need to practice, okay? So you need to listen attentively to ensure your understanding of what the person is saying. So you're not just nodding and thinking about what you're going to have for dinner. Broad openings, so you want to allow the patient to take initiative. So we're going to say, can you tell me more about XYZ? And this leaves it all open for the patient to tell you as much as he or she can about that. Accepting. The patients want to feel accepted, so you want to indicate that you've heard the patient without judgment. So especially in psych or substance abuse, patients are afraid that we're going to judge them. You need to continue asking your questions, continue documenting, continue being there with the patient, but not showing any signs of judgment. Clarifying. If you don't really understand what the person is saying, you can say, can you please clarify what you mean by I don't feel good or I feel angry? Like, what does that mean to the patient? Exploring. So you want to examine a topic deeper. So they might say, I'm feeling very depressed. Okay, well, let's explore that feeling of depression and let's talk about when it started happening, what you were doing, the events in your life that were happening. Focusing. So we need to focus on a specific topic. Sometimes patients like to get off topic, but we need to sometimes bring them back to focus on what we're trying to get out of them. Reflecting. So this is using the patient's thoughts and feelings, but we're reflecting it back to the patient. The patient says, I don't like my family, they're mean to me. You can say, I hear that you are having a hard time with your family because you believe that they are not being very nice to you. Kind of holding up a mirror in front of the patient. Give the words back to them so that they can expand on them. And then restating. Restating and reflecting are kind of similar, but we repeat the patient's words in a different way just to make sure that we're clear on what the patient is really saying and we can really understand what the patient. So things we do not give, and these are great for NCLEX questions or, questions on your exam in class. So we never give advice, okay? It's not our job to give advice. We can listen, we can educate, but we cannot tell them, oh, you need to go home and pack your bag and leave your abusive boyfriend tonight. That's not our role. We don't want to talk about ourselves. This is not about us. This is about the patient. We never tell the patient that he or she is wrong. We can let the patient know facts, such as if the patient is hallucinating and saying there are demons in the hallway, you can say, I do not see any demons. But you're not going to tell the patient, no, there are no demons. You can only talk about your perception. I do not see any demons. I do not hear any demons. We do not enter into the hallucinations or delusions of the client, so we don't say, oh yes, I see the demons too, and they're very scary, because this is going to make the patient believe further that the demons are real. We don't give false reassurance. We talked about this earlier. Everything's going to be fine. Everything's going to be great, because it might not be, okay? We don't give approval to what they're doing or disapproval to what they're doing. Again, our job is to sit and listen and gather data. We never ask why, especially in psych. If you ask somebody why they tried to kill themselves, it kind of puts them on the defensive, and they probably don't want to talk to you about that. So you need to find other ways of exploring that suicide attempt instead of asking why. We don't change the subject because we're uncomfortable. If the patient wants to talk about something that's appropriate but yet uncomfortable, you need to figure out ways to keep the conversation going to collect your data, but we don't change the subject because we're uncomfortable with the subject. We don't defend doctors and the other health team members if the patient says that he or she doesn't like somebody because they didn't feel treated respectfully or properly. We don't defend them. We again listen, gather data, and then talk with the healthcare team on the next steps. So documentation, we always document after we talk to patients, after we do anything with the patients. So you need to know the difference between objective and subjective documentation. So objective documentation is what you are observing. What can you see? You can see the patient grimacing. You can see the patient crying. You can see the vital signs. You can see the patient doubled over, crying and stating that he is in pain. Subjective is what the patient or family tells you. So if I said I am in pain, that is a subjective statement to you. I am nauseated. You cannot see my pain. You cannot see my nausea, but I'm telling you that I am. Anytime we are documenting subjective information, we need to use direct quotes. So patient states, quote, I am in pain, unquote. So objective is observed, S. Subjective, S is said. Objective O is observed. Subjective S is said. So documentation. So we need to document right after we do something, never before, because the one time you document before, something's going to happen, such as you document you gave the medications to the patient, and then unfortunately the patient right then codes, and now it shows that you gave medications, which you really did not give the medication because there was another incident that happened, and now your document you've been called out for your documenting before. So never document before anything. We need to use approved abbreviations for the facility. Abbreviations come and go, it seems like every year, but make sure that you use the approved abbreviations or just don't use abbreviations um, so that there's no uncertainty in what you meant to write. We do not use humor or slang in our charting. We only document the facts. When you make an error on a written document, I know we do a lot of electronic these days, but if you're still using paper, pencil, documentation, if you make an error, you need to place a single line through the error with your initials, date, and time, and write out the word error. We never use whiteout because that looks like something might be trying to be hidden. So any error that you write down, you need to cross it out with one line, write the word error um, with your initials, date, and time. All right, so let's talk about um, the prevention of hazards with immobility. So when our patients are immobile, this affects the entire body system. So we're always thinking about ABCs, ABCs. So when we're immobile, we have decreased lung expansion and an increased risk of atelectasis. So ABCs, we need to get our patients up and moving and expanding their lungs. If they're immobile, ABCs, we have a risk of blood clots, circulation. Uh, if they're immobile, they have a risk of muscle atrophy, so their muscles become weak and they're not as strong as they used to be. Our bones become weak, so we're at more risk for fractures. Our gut isn't moving very well, so we might be constipated. We're not up and moving around, so we might develop kidney stones or a UTI. And of course, risk for pressure ulcers, which is the number one thing that we need to worry about as nurses, aside from the ABCs, when patients are immobile. So immobility effects on the ADLs. So when somebody is immobile, their ability to care for themselves, of course, decreases. Um, but we want them to participate in as many ADL activities as he or she can. So this is to maintain their dignity and their function. So we want them to do as much as they can, even if they are immobile. So maybe they can still wash their face with a washcloth or brush their teeth. We don't want to just take over these ADLs um, because they're immobile. So we have these things called instrumental ADLs. So this is like more of like household work, meal planning, budgeting, like more outside of the house ADLs, not so much like dressing yourself and brushing your teeth and everything like that. So those are called IADLs. But then the ADLs are activities of daily living, like we're normally used to, like brushing your teeth, changing your own clothes, taking a shower, thing like that. So we do worry about deep vein thrombosis when patients are immobile. And so a deep vein thrombosis, you'll hear it called a DVT. It's a clotting in the blood in a deep vein. And usually it happens in the calf or the thigh. So if your patient is immobile and he or she is complaining of redness at the calf, swelling, edema, pain, or a positive Homan sign. A positive Homan sign is when you ask the patient to point his or her toes towards his or her nose. The patient is going to have pain in that leg. We do not want to put a pillow or knee support behind the knees because this can dislodge the clot, but we do want to elevate the leg. We never massage the area because, again, we don't want to dislodge this clot. We can use warm and moist compresses to help decrease the pain. And of course, if our patient does have a DVT and we have a sudden onset of chest pain or shortness of breath or increased heart rate, this could mean that the clot has broken off and is now turning into a pulmonary edema, a pulmonary embolism. So these are signs and symptoms that we need to report to the provider ASAP. So how do we prevent immobility problems? Because our patient is immobile, okay, but we want to keep their lungs working. We want to keep them moving as much as possible. So we're going to promote coughing and deep breathing. So we're going to teach them how to cough and deep breathe while they're in the bed. We're going to teach them how to use the incentive spirometer. Remember, we take a big breath in with that incentive spirometer to see how high we can get that ball. We're going to use compression stockings called TED hose to keep that circulation moving around in the lower legs. You'll probably see the SCDs in the hospital, the sequential compression devices. They're like TED hose, but they're electric, so they squeeze and release on the calf to keep the blood flowing. We're going to give Lovenox, which is an anticoagulant, because we do not want blood clots forming. We're going to reposition the patient every 2 hours because we don't want any pressure injuries to happen anywhere on the patient's body. We're going to encourage range of motion. We know they can't get out of bed, but can they lift their arms up and down? Can they lift their legs up and down? Anything to keep that blood moving. We're going to increase our fiber and our fluid because we want to keep that skin really as healthy as possible so it doesn't break down. And the fiber, we want to keep our gut moving so we don't become constipated. Of course, we're going to encourage the patient to move as tolerated. So this might be working with OT and PT, but this is based on your assessment and what you think the patient needs. So there are mobility devices that can help the patient move. I'm sure you've all seen a cane. So just know that how these devices work, okay? So the cane should be held on the strong side or the good side or the unaffected side, okay? Hold it on the good side. They should be at the height of the patient's wrist. If they're using a four-pronged cane, which you can see here on the left, the flatter side is toward the body and the rounder side is on the outside, okay? So just know that cane should be held on the good side, and they should be at the wrist level. Now, if the patient is using a walker, the walker needs to be at the height of the wrist as well. The patient should have his arms flexed, and the patient needs to learn how to use the arms of the chair to get out of a chair. So if the patient has a walker and he's getting out of the walker, out of the chair onto the walker, the patient needs to push his weight down on the chair before he grabs the walker so the walker does not. We have crutches. So just know that crutches, the pads of the crutches should not be against the armpit. It can cut off circulation, okay? It needs to be actually 2 inches below the armpit. So when the patient uses crutches, they actually put the weight on their hands and not the armpit. There are different gaits you can use with crutches. So the swing through gait, they move both crutches at once and swing up with both legs to meet the crutches. Okay, the 2-point. They move the opposite leg and the crutches together. 3-point. They move both crutches with the injured leg, then they move the other leg. And 4-point, one crutch, opposite leg, other crutch, then the other leg. Okay, just review how to use crutches. Now, stairs. This is important. The NCLEX loves to ask stair questions. So when climbing stairs with crutches, just remember this. We go up with the good and down with the bad. Okay, so when we're climbing upstairs, the unaffected leg, we put that next to the stair railing. We put the crutch under the arm of the affected side, step up with the unaffected leg, and then with the affected leg. Going down, we put the affected leg near the railing, crutch under the affected side, lower the crutch, move affected leg down, and then move the unaffected leg. So just remember, we go up with the good and down with the bad. So when we're going upstairs, we go up with the good leg first, and when we're going down, we go down with the bad leg first.